We are a few minutes early, but if that's okay, we will move on to our next speaker, Associate Professor James Ussher, who's an immunologist and a clinical microbiologist in the Department of Microbiology and Immunology at the University of Otago and Southern Community Laboratories. James' research interests are in applied and molecular immunology, medical microbiology, and vaccines. He will discuss how is COVID-19 diagnosed and what are the future diagnostic possibilities. James.
Thanks, Jackie, for the introduction. So, yes, today I'm going to talk about diagnostics, and I'd have to say that's a hard act to follow, having to follow on from the Director General of Health, but I'll do my best, and please bear with me. So I'd just like to start pre-COVID. So this was by mid-January in Stewart Island, a beautiful day there, not knowing what the storm that was to follow on my return to work was going to be. And came back to reports in mid to late January of outbreak of a novel coronavirus in China, centered in the Hubei province around in the city of Wuhan, and reports of human-to-human transmission. And even though there were only a small number of cases at this point, it was of significant concern. We had cases reported in other countries, including South Korea and Japan as well. So at this point, I had a conversation with a colleague in the Department of Microbiology, Professor Miguel Quinones-Mateo, who is the Webster Chair for virology in the department, and together we decided that this was of significant concern, and that we should try and set up an assay at the Southern Community Laboratories to diagnose this in case we saw further transmission and we needed to have a diagnostic effort in Dunedin. So this was a real team effort, and I'd just like to give a massive shout out to Dr. Jenny Grant, who's the head of the Molecular Pathology Laboratory at Southern Community Laboratories, who did much of the work and got the assay up and running. And also to Miguel's team, Dr. Roderick Harfoot and Dr. Blair Lawley, two postdocs working with Miguel, who helped with the establishment of the assay. So the first genome of SARS-CoV-2 was published back in 10th of January, and researchers around the world, or several groups around the world, designed assays on the basis of that sequence. And one of those was from the Christian Drosten's group at Charité in Berlin, Germany. And that was the assay that we elected to set up. So there were three different targets that he described, one against the RNA-dependent RNA polymerase, one against the E gene, and one against the N gene. We elected to set up assays against the RDRP and the E gene. And we decided to put it on the Panther Fusion. So this is a large piece of equipment. It doesn't have a Panther on it, despite the nice graphics that Hologic provide. But it is, it's straightforward in that it's essentially a black box. You've put the sample in and it does everything for you. It does the RNA extraction and does the PCR amplification. However, there's a lot under the hood that needs to be sorted out for it to be able to do that. And this was an open access assay that we had to establish. And some of the difficulties that we and others around the country, so I'd say that other labs around the country were moving at the same time to set up assays, including Canterbury Health Labs and Lab Plus and ESR. And much of the challenge that we faced was that we didn't actually have any virus to use to set up these assays. We didn't have a positive control. And this was where working with Miguel's group at the university was especially helpful. So he and his team designed plasmids that had a T7 RNA polymerase promoter that was able to be used to make RNA copies of those PCR the PCR targets that we could then use to establish the assay. We're also kindly provided by some cDNA copies from the viral culture by the Vidral reference laboratory from Melbourne, and set the assay up using these reagents. Now, this wasn't straightforward, not having virus and trying to use RNA to validate the extraction protocol as well. But we eventually managed to get it up and running on Friday the 13th in March. So it took a good 6 weeks to get the assay up and running. And it was a bit of an inauspicious day because we had a couple of samples prior to that we'd been sending to Canterbury Health Labs, but the first case that was diagnosed in Southern District Health Board was also on the Friday 13th of March, so on our first day of running, and that was New Zealand's 8th case, and was a tourist in Queenstown. So it was a moment of great relief and really just in time that we got this up and running, because after that we saw a massive explosion in testing. So we went from just a handful of tests that we were sending away to rapidly having to test well over 100 tests a day. And that rapidly spiraled over the ensuing weeks through lockdown, and then as we went from level 4 down to level 3 and making decisions around or helping provide data to the ministry to make decisions around those changes in levels. There was a lot of asymptomatic screening that went on as well. So we peaked at over 800 tests a day from having this having been a test that we had never run prior to January. I'd again like to give a massive shout out to the laboratory staff, so particularly Jenny Grant through this. She was in there virtually every day, far in excess of her normal working hours, ensuring that this was running smoothly. And the laboratory staff in both microbiology and in the molecular pathology laboratories at Southern Community Laboratories, who split into 2 different shifts to try and maintain bubbles and trying to maintain testing through lockdown. So the real unsung heroes in this. Nationally across the country, we saw a similar story. So the rolling average is, the legend is has been cropped, but the rolling average is 7-day averages in yellow, and then you can see the daily swings in red. With even in lockdown, people seem to observe weekends, so we saw dips during weekends, but significant volumes throughout and coming towards the end of level 4, which have then dropped off. But we in the last week or so, we've seen massive increases, and in fact the last 2 days have seen the 2 largest days for laboratories across the country, with over 10,000 tests done 2 days ago and almost 10,000 tests done yesterday as well. So a huge amount of work done by all laboratories across the country. Through that time, we've also built up our capacity. And Dr. Bloomfield was often being reported in the daily reports from the ministry. So currently our capacity nationwide sits at about 12,000 tests, although this is with the return to business as usual that the laboratories have now doing, and we're actually seeing increases in business as usual testing. This is would be absolutely stretching the laboratories to run this amount of these volumes, and in fact the volumes of the last 2 days have been a real stretch in some areas of the country. So there's been a number of laboratories across the country that have come on board and developed tests. Locally, it hasn't been, this only tells the part of the story. So that's the theoretical number of tests we could do per day. The reality of how long we could sustain that for was quite different for much of lockdown. COVID-19 has seen an unprecedented disruption of global manufacturing and supply that has affected many areas, and particularly diagnostic testing. So globally, we've seen a huge demand for reagents required for testing, from swabs through to PCR supplies, and many of those supply chains have been disrupted. For example, many of the swabs that we use for testing come from northern Italy. And obviously, northern Italy was right in the centre of the early outbreak, and very quickly our supply of swabs completely dried up. Similarly, with supply of reagents to run on these large platforms such as the Panther Fusion and different machines at other laboratories quickly became extremely challenging. And we can see this graph here just plots supplies on hand in orange versus the testing rates that we were doing per day and by date along the bottom. And you can see that there were a couple of points where we were sailing perilously close to the wind. So often in Dunedin, we were running with 3 to 5 days worth of stock on hand, desperately waiting for the next shipment, which usually arrived before we ran out. But on a couple of occasions, we had to grin and bear it for a day or two. And just to sort of highlight some of the challenges that were involved in this, around this time period where we did actually run out of testing capability for a day. We had a shipment that had come from the US and had arrived in Melbourne, and none of these shipments were ever what we ordered in volume. They were many-fold less than what we required, but the distributors were trying to make sure that there was fair distribution around the globe. So they were on a sort of global supply, and so we didn't get what we ordered, we got what we were sent. And what we sent often didn't get here in a timely fashion. So around here we had samples, supplies that had been sent from the US and had arrived in Melbourne, or in Sydney, sorry, and then we're sitting on the tarmac in Sydney waiting to get to New Zealand. Took from Wednesday to Saturday to get them from Sydney to Auckland, with 3 flights cancelled. And then the supplies didn't get from Auckland to Dunedin until Thursday, with multiple flights cancelled. In fact, it proved in the end that it was far more reliable to ship supplies by road than to try and send anything by air. So it was an extremely challenging time, and the laboratory staff worked through this extremely well. And to try and maintain our testing capacity through this time, we established, and Jenny and her team established another 3 assays in the laboratory on 3 different platforms to try and diversify our dependence on different suppliers. We worked up mini pooling in an afternoon, on a Friday afternoon, when, just because this was all happening just before just at the same time as all of the surveillance testing and asymptomatic people in various areas of the country was occurring. So we worked up that. She worked that up in an afternoon. So she's been an absolute hero of the response. Okay, so that hopefully gives you a feel for some of the challenges and that the diagnostic laboratories have had to go through. I just want to maybe comment on a few issues now around diagnostic testing, both for molecular testing and serology testing. And some of this has been in the media. Lots of questions around sensitivity of testing and sample type, and I'm just trying to address some of these issues now. So for a start, sample type is extremely important. So originally we weren't sure, and we were asking for both a nasopharyngeal and an oropharyngeal sample, and if possible, if the patient was producing sputum, we also wanted a sputum sample. There's emerging data now that nasopharyngeal is probably more sensitive than an oropharyngeal sample. So in this study here, there was a significant number of patients who were positive on a nasopharyngeal sample who were negative on an oropharyngeal sample that was collected at the same time. So no doubt that although unpleasant, a nasopharyngeal sample is superior to an oropharyngeal sample. Although if you combine an oropharyngeal sample with a nasal swab, even if it's not a nasopharyngeal swab, it may be provide you with, if not quite as good sensitivity, almost as good. It's a bit hard to read this table, but hard to summarize otherwise. But showing by different sample type, but also by data collection, because data collection is also extremely important. The positivity rate in patients, and so we've got throat, nasal swabs, and then lower respiratory tract samples, so sputum and a bronchoalveolar lavage fluid. Just showing that again, a nasal swab's more sensitive than a throat swab, but that a sputum sample is more sensitive again than an upper respiratory tract sample. They've just got the CT values here. So in PCR, a higher CT value is actually reflective of less virus, whereas so the earlier you detect a sample, the more there is. So sputum has got more virus in it than a nasal swab or a throat swab. And you note that if we look at here at the nasopharyngeal and throat swabs in the first week of illness, that sensitivity starts to drop off during the second week of illness, and by the third week of illness, it's really dropping down. So timing is important, the site of swabbing is important, and ideally a lower respiratory tract sample is important. So here's some other data from this out of the German group, from the Drosten group. So here we're just plotting the amount of RNA, viral RNA in a log scale versus the days post-symptom onset, and at the top we've got throat swabs and nasopharyngeal swabs. It's a bit hard to make out the nasopharyngeal versus the throats, but generally the nasopharyngeal have got more virus in them for longer than the throat swabs, but generally there is more in sputum than there is in throat or nasopharyngeal swabs, and it persists for longer as well. Stool's not a sample that we generally look at, but you can see shedding of virus in stool as well. Interestingly, self-collected swabs might be an acceptable alternative. And this is just a recent publication from the New England Journal of Medicine. And interestingly, in Brisbane, this is an approach that's been taken throughout. But in this study, they compared the use of a nasopharyngeal swab that was collected by a healthcare worker as their reference standard versus the sensitivity of various self-collected swabs. The self-collected swabs are slightly less sensitive, so a tongue swab is definitely less sensitive than a healthcare worker collected nasopharyngeal swab. But a nasal swab or a mid-turbinate swab collected self-collect is almost just not that much worse than a nasopharyngeal swab. And if we look at the CT values, so again, down here is more virus, up here is less virus, but generally they're fairly comparable levels between those samples. So it might be that self-collected swabs might be an acceptable alternative and might be less unpleasant than having to go to a CBAC and have a swab pass straight back down your nose. And it feels like it's going to penetrate your brainstem. So just to highlight again the effective timing on that sample and sampling on sensitivity. So this is a meta-analysis of data that was published in the Annals of Internal Medicine. And this is looking at days since exposure. So this is generally the day of symptom onset shown by this line. So this is pulling data from a number of different papers, so different swabbing techniques as well. But generally we can see that those first few days after symptom onset, are the days that are the most sensitive for testing. And if you start testing people later in presentation, then it's going to be, you're less likely to be able to detect the virus with a single swab by PCR. And that you can detect virus in a proportion of people prior to the onset of symptoms. Another important thing that we've noted is that PCR can remain positive, however, in a proportion of people for quite a long period of time. So this is some data out of New York looking at people who are serially tested. And in this large data set of over 800 people, it took 4 weeks for 50% of people to become PCR negative. And this was important from a public health perspective with clearing patients. We had a number of patients who were positive, who remained positive by PCR for a number of weeks and had ongoing symptoms and had to remain technically classified as not having resolved and had to remain in isolation because they remained PCR positive. And in fact, you can detect, in a proportion of people, you can detect PCR positivity for over 40 days. So remaining PCR positive is perhaps not the best marker of infectivity. And while there's not a lot of studies on this, there's emerging data that suggests that if you look at culture, and the reason there's not a lot of data on this is because you need a PC3 facility to culture virus, and there's not a lot of those around the world, and it's not part of routine diagnostics. But if you look at culture, even though you can detect virus out to over a month, you can really culture it after about 8 to 10 days. So you can still detect the viral genome by PCR, but you can't actually, the virus may no longer be infective. There's been a lot of talk about asymptomatic cases and how infectious they might be. So if you look at the amount of virus present by PCR, by RT-PCR, so this is a recent paper from Nature Medicine. These are people who are truly asymptomatic, these are not pre-symptomatic people. So it's important to distinguish between people who are PCR positive who then go on to develop symptoms, who seem to be more important in transmission than people who truly remain asymptomatic. But if you look at you can't distinguish the asymptomatic from the symptomatic people by PCR. So similar amounts of similar viral loads as measured by the CT value. This is against 2 different targets, and those who are symptomatic in pink and those who are asymptomatic in blue. And you also get prolonged shedding in the asymptomatic cases, and in fact in this cohort they suggested there was even slightly longer in the asymptomatic cases. So virologically, asymptomatic cases and symptomatic cases appear very similar in the amounts of virus and in the shedding of virus. Another important development has been around rapid diagnostics. So there's a desire to rapidly be able to detect infections, so that the assay that we have set up in Dunedin is amenable to rapid diagnostics, and that it is a random access machine, so samples can be loaded as they come in, and you can get a result in 3.5 hours. So that was extremely useful for management of hospitalised patients. However, in other parts of the District Health Board, where there were issues around transport first, often we were looking up to 24 hours for a result. And using more traditional molecular methods, as used in many laboratories around the country that are not random access, the testing was often in batches, and often turnaround time was approaching 24 hours. So if you've got a patient who's sitting in the emergency department who you need to manage, you decide whether they got COVID-19 or not, you might want a rapid test. And so platforms have become available that can be used for rapid molecular testing. So one of these is Keffiad's Gene Expert, this is a machine that's already available in multiple laboratories around New Zealand. And this is can give a result within 60 minutes, although it's low throughput and that you can usually only run a handful of samples at one time. But this has been shown to be highly sensitive and specific for detection of SARS-CoV-2. But the platform is important, so there has been some talk around the BD's ID Now, which is a slightly different PCR, uses a different method to amplify DNA and can provide a result in as early as 10 minutes. However, and this has been widely utilised overseas, including, I believe, it's being used in the White House. We haven't really seen these used in New Zealand because it's been very hard to ship these out of New Zealand. Ship these out of the US. They haven't been able to supply kits, but the recent emerging publication suggesting that this platform is not as sensitive as some other platforms. So the platform might be important. And we've now implemented these, try and improve turnaround times in some of our rural hospitals. So we've now placed Gene Experts with these cartridges in Queenstown, Clyde, and Invercargill. There are in other smaller hospitals around and large hospitals around New Zealand to try and improve turnaround times. Although there is a limitation on the ability to access cartridges for these, because again, these cartridges are made in the United States, and we're on a restricted global supply again. Some of the other issues that we have struck is one of the major issues has been around accessing reagents to extract the nucleic acids, the genome of the virus from samples for amplification, and that in laboratories we're often doing this on large robots for high throughput, and these require their own consumables. And that has been one of the reagents that's often been critical in supply for various laboratories around the country. So there is some emerging data that you can do PCR without extraction for detecting SARS-CoV-2, and overall the sensitivity is about 92% if you do it without extraction. So here's the gold standard in blue at the bottom. So this is looking at the CT value. So here's the limit of detection, 40 cycles. So if you're moving up, it's less sensitive. So there certainly is about up to, on average, maybe about 5 cycles or more or less sensitive if you do it without extraction. But overall, most people have large amounts of virus. So the overall clinical sensitivity is still reasonable, but we're certainly losing some analytical sensitivity by using an extraction-free method. But that may be an option if we really can't access supplies. Another rate-limiting step has been, or a great concern, has been access to swabs. And this has been globally, there's been concern around accessing swabs, both with swabs coming out of Italy, where there has been major outbreak and the factories have closed down and we haven't been able to get them. There's been massive global demand, particularly we saw Wuhan swabbing the entire city population recently, requiring over 10 million swabs. So this could be an ongoing issue going forward. And there is some data that suggests that saliva might be an alternative specimen type. So collecting 0.5 ml of saliva, they did this on 103 patients who were positive by PCR on a nasopharyngeal or throat swab. And they found that overall saliva was a pretty good sample type. So about 92% sensitive, especially if you looked early. If you looked later after admission, then it's not such a good sample type, but that is the same as with a nasopharyngeal swab. There's also been some discussion around not using molecular methods, but using rapid antigen tests, so using antibody to detect the virus. However, these have generally looked pretty poor in their sensitivity. So on these saliva specimens, while PCR was 91.8% sensitive, the rapid antigen tests were pretty rubbish, really. And if you can look at that overall, so all of these samples here that had higher CT values tested negative by the rapid antigen tests, and only those that had the highest amounts of virus on them were positive by a rapid antigen test. So I think if these rapid antigen tests are going to have any use, there's going to need to be a significant amount of work done on them. Finally, I just wanted to say a little bit about serology. So serology is detecting an immune response to the virus, detecting antibodies. And there's been interest in this, and there's been lots of talk in the media about using rapid antibody tests to detect people who might be infected. However, these really play a very limited role. So they've got a very low sensitivity in the first week of infection, so only about 30%. Unlike many infections, IgM, which usually comes up first, seems to be unhelpful. IgG seems to be more important. It also seems to depend upon which antigen you look for. So the nuclear protein comes up early, immune responses to the nuclear protein than to the spike. So here's the receptor binding domain of the spike. So you can see the curves have shifted in time to coming up later. So probably these more role in a seroprevalence than they do in clinical diagnostics. There are a couple of good platforms coming on the market now, so Abbott and Roche. So here's the Abbott assay. So the Abbott assay, again, we can see that in the first 3 days of illness, absolutely rubbish sensitivity. In the first week, we might pick up to 30%. Then by the second and third week of illness, we start to see the sensitivity of these climb, and they do have a very high specificity. But if you consider a country such as New Zealand, where we've had very low incidence of infection, then still we're going to have issues with false positives on these assays. So we're running a study at the moment using an antibody test using the Abbott antibody test to see if there has been further transmission in the southern region, looking at highly exposed contacts of cases and looking at probable cases. And this is being led by Dr. Arlo Upton from Southern Community Labs and Susan Jack, Dr. Susan Jack, Medical Officer Health from Southern District Health Board Public Health South, and a number of other people involved, including Alison Craigie, Matt Parry, Nikki Moreland, Gary McCullough, and myself. And this study's underway at the moment, so it will be interesting to see. Just one note of caution finally, we do see there's some recent data coming out to suggest that antibody levels may decline during convalescence, but I would note that neutralising antibodies remain detectable, which even if they do fall back slightly. So this might be an issue for diagnostic studies, but it does seem that neutralising antibodies remain detectable even in asymptomatic cases. So I'll finish with that, and if anyone's got any questions. Thank you.
Thank you, James. Would you like to scoot up next to me? I can go through some of the. Sure. We have about 2 minutes or so for questions. Firstly, how does the method of testing, oral swab versus nasal swab for SARS-CoV-2 compare to other coronaviruses?
Sure. So other coronaviruses aren't viruses that we are usually of great diagnostic interest. So thinking of the human endemic coronaviruses, so there's 4 human endemic coronaviruses, and they generally cause the common about 10 to 30% of common colds. They are on some multiplex panels. So usually the viruses that we're interested in from a diagnostic perspective are influenza and RSV. Generally, we find that nasopharyngeal swab is a more sensitive specimen type than a throat swab for most viral infections, but I'm unaware of any studies, or there may be out there, but I haven't seen any studies that specifically have looked at coronaviruses. They're not, as I say, usually of massive clinical interest.
Okay. Media have reported non-testing for population groups, including children. Given your slide about self-testing, would a simple nasal swab for children be better than no testing at all, understanding that patients may be reluctant to give informed consent for children to undergo a nasopharyngeal swab?
Yeah, no, that's a great point. So we certainly had issues with several of the probable cases related to children. because after the parents had had a nasopharyngeal swab, they declined for their children to undergo the same procedure. So I certainly think that there's no doubt that a nasal swab or a throat swab would be better than no swab. And while it is maybe not the most sensitive, I think it would be a very good option. And I think going forward, it's something that we should be considering, especially for surveillance testing where the pretest probability is a lot lower.
And are we likely to have very high throughput testing available at some point?
I'm assuming that's for serology. So we do have high throughput molecular testing, high throughput serology testing. So certainly both the Abbott and the Roche assays are run on high throughput platforms, and could be established in diagnostic laboratories. The question is whether there is what the diagnostic need will be for serology testing, what its place is in clinical management outside of studies. So it may be that at some point at the border, it might be something that's of some utility. But yes, no, I mean, there certainly are assays that are available on high throughput platforms, and whether they are available in New Zealand will depend on what their role might be in clinical management.
Thank you. We're out of time, but we've only got one more question, so we'll just go with this one quickly. Who is being tested in the Southern Antibody Study?
Right, so we're looking primarily at household, so the close contacts of confirmed cases. We are looking at healthcare workers, and we're interested in as well in particularly people in Queenstown, tourism workers, people who may have been tested by PCR and have tested negative during lockdown. So those are the primary groups that we're interested in. So it's not a true seroprevalence study because we're not taking a representative sample of the population, but we're looking to see if there's an idea of how much additional transmission there has been in those high-risk groups.
Thank you. So that's all for today. Thank you to Associate Professor James Ussher. Thank you to Marissa and to Dr. Ashley Bloomfield as well for their presentations. And thank you to you for attending. We will be back in the masterclass on Monday, 29th of June, starting from 12 noon New Zealand time. See you then. Ngā mihi.